This is the 7th webinar in the Minnesota Drug Diversion Prevention Pathway webinar series, PRN Considerations in Preventing Drug Diversion. PRN-controlled substances create a unique challenge for preventing drug diversion in long-term care. Intentional thought around PRN medications is necessary to decrease drug diversion risk. Because PRN administration is based on judgment, different nurses will rightly have different thresholds for administration. PRN medications prescribed for residents with cognitive difficulties are also a challenging combination. Multiple studies indicate that patients with cognitive impairment receive far fewer pain medications after orthopedic injury or surgery than people who do not have cognitive difficulties. One study showed a 2/3 decrease in the amount of pain control medication administered. It is also easier to divert medications from a patient with cognitive impairment based on their inability to remember or communicate about their pain or medications they have received. There are some common behaviors that occur with PRN diversion. There may be a nurse who is vocally passionate about controlling a resident's pain. They may be the only one giving PRN narcotics to specific residents. These residents may not be getting the medication. A nurse may consistently rate a patient's pain higher than other nurses, always choosing the higher PRN dosage. The nurse may give one pill and pocket the other. A nurse may recognize the volume issues or overage with liquid-controlled substances and may pull off extra or dilute the medication. Nurses may also choose to work on a memory care, rehab, or psychiatric unit, or may request working night shift based on their belief that it will improve their ability to divert. There's balance. It is easy to think you know your staff and they would never divert controlled substances. It is also easy to start seeing opportunity for diversion everywhere. The drug diversion prevention pathway is organized based on the prescription drug life cycle. Within the pathway, there are several facility recommendations for PRN medications, but leaders should consider PRN medications in every step of the prescription drug life cycle and should have PRN prescription monitoring in place as a part of their monthly pharmacy review. Prescribing and dispensing. Adhering to quality limits for prescription length, quantity, and dosing for PRN medications ensures resident care that aligns with their medical condition. Providers often want to make sure that they order enough medication that nurses have plenty of options to successfully treat pain, anxiety, or other symptoms in their residents. Quality limits ensure that if a provider's prescription is outside of the range of normal, they have a conversation with the nursing or pharmacy staff to discuss the care plan for that resident. Analyzing provider prescription patterns can also help to understand PRN usage. There are times when one provider is prescribing significantly more controlled substance than their peers. Remember, this can be appropriate. Involving the medical director in these discussions to ensure adherence to current recommendations and ensuring robust, non-narcotic pain or behavioral interventions can decrease the amount of PRN medications needed. Procurement and delivery. Most often, PRN medications follow the normal pathway for check-in, but sometimes PRN medication must be delivered urgently. This may occur via a local pharmacy or a courier service, and medications can be delivered at a different time than usual. For these deliveries, there is inherent risk. The drug diversion prevention pathway recommends that facilities have a process where controlled substances are delivered directly to nursing staff and ensures that medications are never left unattended or dropped off when they are delivered. It also recommends that facilities have a process for 2 staff check-ins of medications. One individual must be a nurse or pharmacist, and the other individual must receive training on the check-in process. These processes should be in place or modified to ensure off-hours deliveries meet the same standards. Storage and security. PRNs may sit without use for a while. Use can be sporadic and unpredictable based on resident condition. Counts are the same over time, creating clinician complacence. Counts are the same over time, leaving the medications rife for tampering. With medication amounts that do not change, clinicians may justify diversion based on a belief that they are not harming their residents or that medication doses would be wasted anyway. The drug diversion prevention pathway recommends that facilities and pharmacies work together to identify a process for the pharmacy to complete partial fills of prescriptions. It also recommends that the facility has a process in place to review and discontinue PRN-controlled substances that have not been administered in greater than 30 days, unless there is a resident-centered rationale for continuation. The rationale behind both of these recommendations is that decreasing storage amounts of controlled substances decreases opportunities for diversion and improves safety. For preparation and administration, it is important that PRN dosing and indications are clear, especially when there are options for a larger dose and a smaller dose. The Controlled Substance Administration Review process was designed for leadership to analyze clinician administration patterns. It involves collecting and reviewing every administration of a controlled substance over a period of time, weeks or months, as a mechanism to improve safety and to determine if there are aberrant administration patterns among your nurses. The Drug Diversion Prevention Pathway Toolkit has a guidance document for the Controlled Substance Administration Review process. Documentation should allow someone to follow the story of a resident receiving PRN medications. Facilities should have clear expectations for documentation and justification of PRN doses that are given, and follow-up documentation to assess if these medications had their intended effect. Most facilities use a hybrid approach for documentation, showing the administration in the electronic health record, but keeping the controlled substance count on paper. Facilities should analyze this documentation to make sure it makes sense and allows clinicians to easily follow established processes. Destruction and waste. As patients are discharged, there is opportunity for diversion with leftover PRN medication, especially in long-term units with high turnover, such as rehab. Nurses may document administration of a final dose of a controlled substance for the road that is never actually administered. Nurses may also document administration of additional doses on the counting log without a corresponding dose in the patient health record. The flexibility of PRN medications creates additional complexity and opportunity for diversion. Awareness and good systems, along with surveillance, can decrease this risk to facilities and residents.